So, good afternoon, everyone. Welcome. My name is Nicole Wolf, and I'm a child neurologist in Amsterdam at the Amsterdam Leukodystrophy Center. And I see 3 families, I think, right? And 2 researchers. And Katrina Moore from Jonas, who will talk after me. And then Priska, also from Amsterdam, who is liaising our center with industry. So you have an idea who is here. We are a very small group, so please ask any question you have also during the talk. Just don't wait until the end. I think it makes it much nicer with so few people. So those are my disclosures. And just to tell you what our center in Amsterdam is or does. So it was founded by Mario van der Knaap already, I think in 2000, so quite some time ago. And in the beginning, the center was actually focused on MRI analysis and description of new leukodystrophies, because at that time, many patients didn't have a diagnosis, Pelletier-Merzbacher being an exception, because that's a disease we've been known for a very, very long time. And then when we described new leukodystrophy, usually from the MRI appearance, we tried to find the genes causing that leukodystrophy. So we identified quite a few genes. But now that's a bit completed more or less. So most patients, about 90% of our patients have a definitive genetic diagnosis. So our focus has shifted a bit on natural history studies, understanding disease mechanisms. So we use mouse models or cell culture models, stem cell models, improvement and also development of treatments, treatment trials. And we also have a quite active autopsy program, because we can learn a lot from studying patient tissue. And quite a few of our patients, I would estimate it about a third, donate their brain to this kind of research after they've passed away. And that's very important also to find disease manifestations. And I mean, for example, the treatment trial for vanishing white matter wouldn't have been possible without studying patient tissue. We are 3 child neurologists working in the center. So we care for patients with all leukodystrophies, children and adults. And our research foci are vanishing white matter, megalencephalic leukodystrophy with the subcortical cysts, and Alexander disease. Those patients and research and trials are done by Mario van der Knaap. Mark Englund, you might also have seen here, because we are here, all of us are here. He's very active for adrenoleukodystrophy and other paroxysomal leukodystrophies. And I focus on hypomyelination, especially for age leukodystrophy and Pelletier-Merzbacher, but also on metachromatic leukodystrophy. And we have a quite a active group. That's not all of the group, consisting of child neurologists, obviously, but also MRI physicists, lab technicians, stem cell biologists, electrophysiologists, molecular biologists. And you see, fortunately, also a lot of very enthusiastic and bright PhD students, because we also want to continue the field. So that's Amsterdam. If you talk about Pelletier-Merzbacher disease, you need to understand a bit about myelination. That's a process where the very thin, very long, and very fragile nerve fibers are actually wrapped by those multiple myelin sheaths, and that process starts already in utero. and it continues at a very well-defined pace until it's more or less, at least on MRI, completed at the age of 2 years. And how that processes over time has been known already for more than 100 years. You see here those tissue stainings with a silver staining, which is a very complicated but very beautiful staining. And this anatomist has described that process at that time already very much in detail. And what is myelin? It's produced by cells called oligodendrocytes. And myelin actually are membrane wrappings around those thin axons. And myelin consists mainly of fat and also of proteins. And the most important myelin protein and is about which make about 50% of all myelin proteins is proteolipid protein 1, which is the protein defect in Pelizaeus-Merzbacher disease. And there are other myelin proteins. And when those wrappings are done around the nerve fiber, they need to be compacted. So they are a bit loose, and then they need to be very tight around the nerve fiber. So that's like a zipper. You can, and that is something we can't actually see well or directly on MRI, but indirectly well. So you can have some myelin, which is immature, we call that, which is loose around the nerve fiber, and probably not as efficient as a well-compacted myelin sheath. So you need to have a really good and normal myelin for the nerve fiber to function properly. And it's a very complicated process, normal myelination. You need, of course, those oligodendrocytes who make those myelin sheaths, who then wrap around the axons, but you also need normally working axons giving signals to those oligodendrocytes. I want to be myelinated. You need astrocytes who provide fatty acids, for example. You need other cell types giving other signals to those oligodendrocytes. And you also need thyroid hormones, for example. So it's a very complicated process, which is very well regulated. And we can follow myelination beautifully on MRI. And you see those two MRI images taken with different techniques of a newborn and of a child of 2 years. And you see that the white matter signal here is almost white, and here almost black or very dark gray. And for this method, it's the other way around. It starts with a dark gray, and the myelin deposition makes that the signal gets whitish or almost white. And you also see that this technique actually shows us much earlier than this technique a more or less normal picture of myelination. And that's why that's because this technique is more sensitive to those more immature and less compacted forms of myelin. And when we talk about hypomyelination, that means significant and permanent myelin deficit. We can see that on MRI, because MRIs of children with hypomyelination look very much like MRIs of newborn babies, like you see here, and not at all like MRIs of a normal child. Yes, sure. Mm-hmm. 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 That's yes. So the question is, there's a child who had an MRI, the first MRI at the age of 6 months or 3 months, 3 months, and then a repeat MRI at the age of 5 months. Sorry, you're right, 5 years old. And the MRI at 5 years old was said to be normal, although that child has a PLP1 duplication. And that's very unusual. I would do that. I would also look again at the MRI, although if someone with experience in children's MRI says it's normal, I would believe it. But it's very unusual. I've never seen it, to be honest. Yes, I think. Mm, 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 mm. Yes. Mm, yeah. Yes. Mm. Yeah. 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 And why do you need myelin? You need myelin for a fast conduction of nerve impulses, so fast transmission of information actually. But that was actually for a long time what we thought would be the role of myelin. But we know now also that those myelin sheaths are needed to protect the axon. And I think that's very easy to understand, because those axons are really very long and very thin, but also to provide micronutrients to those long axons. So Pelletier-Merzbacher disease, at least in the Netherlands, is the most frequent hypomyelinating leukodystrophy. There are many more, as you can see here. There are some really super rare leukodystrophies with hypomyelination, where we know worldwide perhaps 10 patients or even less. But Pelletier-Merzbacher disease is quite frequent and often actually the only diagnosis, for example, neuroradiologists know. So when they see an MRI of a child with hypomyelination, they directly say Pelletier-Merzbacher disease. And we still find some new genes, although I think almost all patients have a genetic diagnosis now. And the disease was first described in 1885 by Friedrich Pelletier, a neurologist. And he described a large family, and he already actually recognized that only boys were affected, and the mothers he already thought must transmit the disease, but didn't develop symptoms. And it's a very long, I think it's like 140 pages description, very detailed description of those patients, which is impressive. And he got it really right. Merzbacher, Ludwig Merzbacher, was a pathologist. He did an autopsy of, I don't know, 1 or 2 of those family members of the initial family described by Pelletier. So that's why the disease has this bit complicated name. So how's the setting in the Netherlands? We are a small country with 17 million people, and also regarding surface, a small country. I think we are the country with the densest population in Europe. So people are really stuck on each other. Distances are not very long, certainly not for people from the US. So all Dutch patients are referred to the Amsterdam Leukodystrophy Center. And they visit 1 to 4 times yearly, but it depends on age, it depends on extra problems and so on. So some patients we see more often, some patients, certainly the older ones, we see less often. Usually they also have local pediatricians and physiatrists, but for example, expert spasticity treatment with operations or scoliosis correction and so on, that happens in Amsterdam. And we, as I mentioned, we take charge of adult patients. And in Europe, you have you can get recognized as an expert center nationally and also Europe-wide. So we are part of the European reference network for rare neurological disorders, where we also see other colleagues from other European countries, and we can also see patients from other European countries in Amsterdam. Any questions so far? No? So I think you probably know more about the clinical presentation of those children than many child neurologists. The classical presentation, and that was what for a long time what was ingrained in the heads of people taking care of those children, is an early onset pendular nystagmus. So that means eyes having this relatively slow pendular movement, and patients, babies are often a bit floppy before they go on developing spasticity later on. They have ataxia, which means very uncoordinated movements, sometimes also dystonia, which means abnormal muscle contractions. So they have some abnormal positioning of their hands or feet, for example. Increasing spasticity, so that means increased muscle tone, stiff legs, less arms. Patients do have, most of them, intellectual disability, although that's less severe, often much less severe than the motor impairment. But it's difficult to test. Many patients are not able to speak, and other patients have a more or less normal speech. They can make very complicated and long sentences, even in the classic form that is very divergent. And sitting without support in the classical presentation is usually not possible. I think many of you and many of us also have seen things which are not so well described yet, but I know quite a few patients with this classical presentation who have problems with autism or autistic features. Vomiting is a problem. You are nodding, perhaps you've heard it or experienced it. Yeah. So, of course, you have your swallowing problems, which are more or less severe. Huh? There are patients who don't have any problems during the first 10 years, and other patients have need a gastric tube very early on. But what we also see is that patients really have a developmental progress in the first years. They develop head control. Some go on to sit without support, although it's the minority in this classic group. They learn to talk. The patients who do talk definitely then learn to communicate, even if they don't have verbal speech. So there is a progress. It's not like patients who, because they don't develop so much myelin, they don't have developmental progress. Then you have a stable phase. And then in almost all patients, we see a slow deterioration. So that's a progression of the spasticity, more problems with swallowing, increasing scoliosis of the back, for example, contractures. And that usually sets in at the end of the first decade, beginning of the second decade. Life expectancy is difficult to predict, but I have patients who are 40 years old. And also in the initial publication of Pellicer's, which is remarkable because it was in 1885 when we didn't have any extra treatment like gastric tube feeding or so, those patients actually survived beyond the age of 30 years. I think that's important to keep in mind because I see many patients who are told that who were told that the life expectancy is 5 to 7 years old. And that's for the severe cases, sometimes sadly the truth, but it's certainly not for the classical presentations. So the genetic background, we have variants in the gene encoding the proteolipid protein 1 or PLP1, which is, as I already mentioned, the most abundant myelin protein, and that's expressed in oligodendrocytes. And there are 2 isoforms, which means the gene can be transcribed in a long form of the protein, which we call PLP1, and in a shorter form, which we call DM20, which lacks those amino acids here. So it's a smaller protein. The most frequently found abnormalities, and that's written up, but to be honest, I'm not sure whether that's true, are the duplications. We always thought it's 60 to 70% of all PMD cases, but personally, I think that's perhaps half of the cases, perhaps even slightly less. And I think that's because, of course, sequencing of the gene was later available than the analysis for the duplications. And some patients suspected of Pelizaeus-Merzbacher disease only get the duplication test, and others only get the sequencing. And in both cases, obviously, you can miss patients. So I'm really very curious to know what comes out the natural history studies. I think for the Netherlands, I can say that we have perhaps half of missense mutations, so small mutations and the duplications. Some patients have what we call a null mutation, meaning you have a variant in the gene leading to no PLP1 and no DM20, so no PLP DM20 protein. And that's sometimes also called PLP null syndrome. Those patients are often said to be mild, and that's true for the beginning. They are less severely affected than patients with a duplication, for example. But those patients show quite a significant and severe decline. And the PLP null patients I know are certainly not mildly affected. And then you can have even higher copy numbers, so not 2 copies of the gene, but 3, or we know one patient with 5 copies of the PLP1 gene, and those children are severely affected. And then you can have what we call deep intronic mutations, which are very hidden mutations in your DNA. You don't find them if you do standard DNA testing for PMD. You really have to go in depth with PLP1 testing to find those mutations. And there is a whole clinical spectrum, and we know reasonably well for at least some of the variants in the PLP1 gene, which gives rise to a mild form and which gives rise to a severe form. You see that the classical form is the most frequent. That's also why it's called classical form. You have this conatal PMD, where patients have at birth already problems breathing. They have a stridor, which is very noisy and difficult breathing, which actually can improve, usually improves over the first 2 or 1 or 2 years. And even with the classic form, what I said already, you have a relatively wide spectrum. It's you can say it's a group of different disorders, or I think better to call it a spectrum from a severe to a very mild end. What we've actually thought already is that the amount of myelin you see in those differently affected Pelizaeus-Merzbacher patients roughly correlates with clinical severity. So the most severely affected patients have the least myelin on MRI, and the very mildly affected patients have an almost normal MRI. So I would be very interested to hear how the clinical presentation of your son is. Yeah. 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 Yeah, it is. And I think the autistic features are really under-recognized, and they are also present in the nonverbal patients who are very much stuck to a routine and hate visits to the hospital, actually. Yeah. 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 Yeah, and quite a few patients I know are fascinated with trams or lifts or escalators. No, and many of the typical patients love music. So I have patients. Yes, yes, and I have patients, and I think it's the only group of leukodystrophy patients I saw that. When I look at them and do the neurological examination, part of it I do on a stretcher, not all of it, because they hate it. But the things I need to do, I do on the stretcher, and very often the parents put a telephone with some music on next to the child on the stretcher. And that's the only patient group I know I've seen that. Yeah, so they really like music. I don't know. I mean, you are the experts on this. Yeah. So there is only a symptomatic treatment, so treatment of spasticity, for example, treatment of scoliosis, helping with communication, a good wheelchair, and so on. But there is no causal treatment yet, and as you all know, it's an ultra-rare disease. We do have mouse models, which is an advantage, but experience also with other disorders has shown that not all mouse data are relevant for humans, and not all treatments that work in mice work in humans. We have a lack of natural history data, and that is about to change, but still we need a lot more of information. And we also added patients from our center to the CHOP natural history study, and those are really needed to decide whether a treatment works or not. The lack of myelin is one thing, but it's not the only factor for the disease. For example, the slow deterioration, you can't really explain with the lack of myelin. And then there are disease individual treatment approaches. So per disease, specific things like gene therapy focused on that gene versus influencing global disease mechanisms like inflammation, which is certainly a part in Pelizaeus-Merzbacher disease, and also axonal health. So there are discussed and sometimes already tried different treatment approaches for PMDs. Some of them have been tried in animal models, some in cell models. You could think of alternative substrates for the axons to maintain the axons, because the myelin cells, the myelin actually provides lactate and glucose to the axon, but you could think of circumvent that partially by giving a ketogenic diet that has been tested. You could think of treating the inflammation. I think that has also been done in some patients. That wasn't so successful for other leukodystrophies. And from the things I've heard from those single patients, it didn't work so well either. There has been a small trial with 4 boys who received a transplantation of neuronal precursors directly into the brain. I think you've all heard about that. It didn't have clinical effects, but it didn't have side effects either. That was the positive message, actually. Then cholesterol has been tried, curcumin, for animal models, positive results, but only with a single patients treated. Cholesterol, for example, is a problem in because we don't have a cholesterol which goes over the blood-brain barrier, actually. So we don't get it into the brain. And if we would get it into the brain, we don't know whether it would have effects. And then there have been already tests in animals to decrease the gene dosage in the patients with at least with a duplication, with what we call antisense nucleotides. And then you need to take care not to knock out the PLP1 completely, because you need some PLP1 for your myelin. We will start a very small study in Amsterdam. And this is actually based on findings from a group from David Roach and Marius Wernig. They are in the UK and California. And they saw actually in a study of PMD cells that iron metabolism was altered, which is called ferroptosis. And gene correction normalized these changes, and a treatment with the iron chelator, that's a medication you use for patients who need a lot of blood transfusions, and because then they build up a lot of iron in their body and you have to get that iron out. For that, you give iron chelators, and that was successful in cell cultures of PMD oligodendrocytes and PMD mice. So we do a very small trial, a sort of proof of concept trial in a group of the very severe connatal PMD patients to see whether that works. So that hopefully will start soon, because I expect the IRB approval for the next week or so. It's not a treatment without possible side effects, because you can get a lack of white blood cells through that medication. So you need weekly blood tests for those patients, which is the main problem of the trial, actually. And that will take 12 months, and we look at the motor function in those children. Any questions so far? No? So we will do that because it's such a small number in the younger children until the age of 8 years, and the severe forms. Here, a classical form is still written, but we will include only patients with the connatal and the transitional forms. We don't include for the small trial older patients, because many of them already have some brain tissue loss, probably due to axonal damage. And we don't know whether those axons will still be able to be myelinated. And for the milder patients, they show better motor development and myelination anyway, even without my treatment. So if I would treat a very young patient, I might mistake normal evolution, disease evolution, for treatment effect. So that's the reason why we, for this very small trial, concentrate on the severe patients. So regarding symptomatic treatment, we look, of course, at growth and weight gain and swallowing function and the appropriate interventions. The treatment of spasticity is something important for PMD patients, and it depends on the disease severity and the age of the patient. And that's always a very individual decision, but what are possibilities are local injections of Botox, intrathecal baclofen with a pump, a medication pump, or an operation where we disrupt some nerve roots close to the spinal cord, which we call selective dorsal rhizotomy, which makes also the legs less stiff. Then you treat orthopedic complications like scoliosis surgery, hip surgery, but also this needs careful evaluation, because especially scoliosis surgery is a big operation, and some patients are already at that age, and that's usually during puberty, quite fragile. So it's always a important decision to do it or not to do it. But if we think it's necessary, it's usually well tolerated because we prepare the patients very carefully. They're admitted on the ICU for as long as it's necessary after the operation and so on. And then considering prophylactic antibiotic treatment, for example, for the recurrent airway infections. So those are examples for the symptomatic treatment. The question, of course, is whether you can actually start myelination, and I think that's needed in Pelizaeus-Merzbacher disease later on in life, or is it restricted to the first 2 years, or perhaps a little bit later than the first 2 years? And that's a question we don't have a good answer, obviously, yet, but we had a patient group actually who looked exactly like Pelizaeus-Merzbacher patients in the first 2 years of life, and had also typical PMD MRIs at that time. But actually at the end of the first year of life already you saw them developing better than the normal Pelizaeus-Merzbacher patient. And when patients actually were followed with MRIs, they had a more or less normal myelin development. And that's encouraging, I think, because it shows us that we can also have a window larger than the first 2 years of life to initiate myelination. And that's also the case for other hypomyelinating disorders, at least I hope that. So I think it's important to remember it's a disorder with varying severity. I didn't know, I didn't say anything about female carriers, mothers with the variants, because certainly mothers with mild variants, well, relatively mild for the boys, very often develop symptoms between the age of 30 and 40 years. And those symptoms consist of problems walking, mild spasticity of the legs, and urinary incontinence is a big problem. So we always have to think of asking those moms about those symptoms, because it's not rare that they do have them, but never thought of going to the doctor with this kind of things. We also, with the new genetic techniques, identify more frequently girls with PMD, or so not female carriers, but really patients, and some of them look exactly like the boys. We need more information about the natural history. I think you all are aware of that. We have, together with a colleague in Heidelberg, Inge Harting, and Adeline Vanderfer from CHOP, developed an MRI scoring system, which we think is useful for clinical studies and also retrospective natural history studies. I think that MRI is a good biomarker. We don't know yet whether there are other good blood or CSF biomarkers. Neurofilament light is a protein we can measure in CSF and also in blood, which tells us something about how the axon is doing. So that's an interesting biomarker for PMD. We have some first data. Actually, I forgot to copy that graphic here into the presentation. I think it has the potential to be an interesting biomarker, but we need more samples with good correlation to the clinics to decide on that. And we don't have a good protein or other marker in the blood or in the CSF where we can actually see how good the myelin is doing, or how much myelin is there. So we would like to have a biomarker like that. And clinical studies are starting, and that's, I think, a very good thing. And we've waited for a long time for that. So we have a very nice collaborations, especially Inge Harting, who's the neuroradiologist and works on the MRI scoring system, Adeline Vanderfer, Grace Hobson, of course, and PhD students in our center, and geneticists, pathologists, MRI physicists, Mario, of course. So thank you, and I hope you have some more questions. Yeah, I mean, we always think of myelin to be very static. I think it's not quite the case, but we also know that, for example, PLP is, I think, one of the proteins with the longest half-life. So it's not so dynamic. And the question is, of course, until when can axons actually provoke, or axons who have been unmyelinated or not very well myelinated, until what time can those axons actually be receptive of myelination or inducing myelination, just how you would like to call that. Yeah, I think it's an open question. It's not normal axons you have after many years without myelin, so that might be a problem. Yeah. Yeah, I mean, we know that there are throughout life there is a pool of oligodendrocyte precursor cells of OPCs present. So that's actually encouraging for those treatment studies. But I'm more concerned about the axons actually. The DM20 is found in peripheral nerves. So if you have variants who abolish the entire protein, then you get a peripheral neuropathy. In the females, no, it's also with the slight spasticity, you can develop very easily incontinence. So I think the peripheral neuropathy is not so important for that problem. Mm. And sometimes it's very easy to treat that with medication, or at least improve it. So it's always important for us to remember asking mothers about symptoms. More questions? Yeah, yeah, thanks. It's an interesting question. I think it's perhaps even more important to recruit new oligodendrocyte precursor cells, because in PMD, you have this oligodendrocytes who don't even reach full differentiation stage. So you wouldn't expect them to make more processes, but you would expect the existing OPCs to be able to differentiate into the myelinating oligodendrocytes. Unfortunately, there is a niche of OPCs in the brain.
Hello, I'm Katrina Moore, and I work at Ionis Pharmaceuticals. And I'm here to talk to you today about a caregiver assessment of disease impact in Pleitzius-Merzbacher disease that we performed. So just to give you a brief overview, I'm actually not going to talk about the background of PMD because Nicole did a lovely job of that. So you should hopefully all be familiar. But I'll talk through the steps of developing the PMD survey and then the findings. So specifically the demographics, the path to diagnosis, PMD symptoms, the impact that has on PMD patients, the current medication and treatment, and also just thinking about future treatment of PMD. And then I'll just finish with some conclusions. This covers basically everything that Nicole just outlined for you all. And I think the main thing that I wanted to highlight here is really that PMD is a spectrum of disorders, and Nicole's gone into detail. And so as part of this survey, we captured really the full spectrum of PMD. So the background to the survey development, so there's a high unmet need for disease-modifying therapies that might, for example, restore myelination in the central nervous system of patients with PMD. And so prior to any disease-modifying therapy entering the clinic, it's important to assess the impact of the disease from the participant or the caregiver perspectives to be able to appropriately evaluate the potential benefit in this patient population. So this was the design of our survey. So we began with interviews with 4 caregivers of children with PMD, and these were identified through the PMD Foundation. And it was kind of a semi-structured discussion. And so caregivers were asked open-ended questions about their experiences, such as details of the diagnostic process, how symptoms of the disease affected the caregivers and also the patient's lives. And they were also asked about the most bothersome symptoms and any expected outcomes that they would see from any PMD treatment. So following these caregiver interviews, we developed a 73-item survey to assess the path to diagnosis, evaluation of current treatment and current symptoms, and also the identification and the impact of the most bothersome symptoms and any significant unmet needs in managing PMD, and also likelihood of future participation in research and also clinical trials. And so as part of the survey, participants were asked to rate symptom severity on a scale of 1 to 10, where 1 was used to represent the least bothersome symptoms and 10 the most bothersome symptoms. And prior to distribution of the survey to the PMD patient community, the survey was reviewed by PMD experts, both medical and genetic experts, just to make sure we were asking the right questions. And the way that the survey worked is that as participants answered the questions, it would only pull up relevant questions following that. And so our aim of this was to be able to facilitate the online survey and then to be able to integrate the findings into a most bothersome symptom questionnaire that we might be able to use in interventional studies. So this is actually quite impressive. We got 100 participants completed this survey. Most of those were sourced through the PMD Foundation, although I'll show you in a second, we had quite a large geographic distribution. 99% of those patients were caregivers, as you might expect, with 1%, being participants that felt that they could answer for themselves. 92% of the patients with PMD were male, and 94% were Caucasian, and the majority of them were genetically tested. And the average age of the patients that were described in the survey was 13 years old, but that did range from 1-year-olds to 36-year-olds. And that was conducted last year. So the mean age of participants, as I just mentioned, was 13 years old, but actually 67% of the participants that completed the survey were under the age of 18. As you would expect with an X-linked disease, 92% were male, as I just pointed out. And the table on the right here just summarizes the countries where the caregivers were located. So you can see we had just over half in the US, but we had quite a large number in Brazil and also in Europe as well. So looking at the path to diagnosis. So caregivers reported the symptoms of PMD presented at birth in 40% of participants at between 3 to 9 months of age in 36 participants, but 95% of all participants were symptomatic before the age of 2 years old. The initial symptoms included nystagmus, which is that kind of flickering eye movement that Nicole described, so 80% of participants reported that being the first presenting symptom. Delayed developmental milestones, hypotonia, the inability to support the head were also listed as common first symptoms. On the path to diagnosis, we found that 95% of participants interacted with a pediatrician and a neurologist, with neurologists providing the diagnosis of PMD in about 49% of cases, and 38% of diagnoses were actually provided by the geneticists. The average age at PMD diagnosis was 4.5 years old, with only 25% of participants being diagnosed before the age of 1. The remaining participants, the diagnosis occurred, as you can see here, for 25% of participants before the age of 2, another 25% between the age of 2 to 5, and then the remaining 25% after the age of 5 years old. We asked participants in the survey if they received a diagnosis of classic PMD, conatal or severe PMD, PLP1 null syndrome, or spastic paraplegia or another diagnosis. And so the most common diagnosis reported by patients was classic PMD, followed by severe or conatal PMD. Some people did not give a response. 8% had spastic paraplegia type 2 and 4% had this null syndrome. And for participants that responded with other, they noted receiving a diagnosis of a mix of classic or conatal. Misdiagnosis was common and was actually reported in 40% of cases. The most frequently common misdiagnosis was cerebral palsy, but it also, other misdiagnoses include mitochondrial disease, pure spastic paraplegia, lack of oxygen, ALD as well was a common misdiagnosis. 95% of participants underwent genetic testing to confirm the diagnosis, and the majority of participants had at least one family member tested, most commonly the mother. There were several challenges in getting genetic testing, and these included waiting time to first appointment, cost and insurance coverage, the length of time waiting for the genetic confirmation, and also them thinking about the impact on themselves and other family members in receiving a positive result was one of the challenges. There were only 4% of families that weren't offered genetic testing, and encouragingly 30% of families had no challenges when they underwent genetic testing. Most received genetic confirmation in less than 4 months, but some families waited up to 14 months for genetic confirmation. And I think what's important to highlight here is we do have a few participants who are older that were captured in this survey, and that may have been before genetic testing was kind of, common practice. So that accounts for that longer duration here. So looking at the PMD symptoms, so across all phenotypes, the most frequently reported symptoms were difficulty with gross and fine motor skills, and also speech and communication. And so I've pulled some anecdotes here from some of the caregivers that kind of capture what's highlighted here. So, we had somebody say there was a difficulty walking, standing or crawling. They can't do any of these things, and it requires the caregiver to move them wherever they go. Moving around limits daily activities, and they can't take care of themselves. And also poor dexterity affects everything from entertainment to self-care. So I just pulled out here, looking at the most common PMD phenotypes. So this is looking at classic PMD, so PLP1 duplications, and conatal PMD, which tends to be missense mutations. And across this, the most common phenotypes were constipation, difficulty with communication, difficulty eating and or swallowing, difficulty holding their head up, difficulty standing or walking, difficulty with manual dexterity, fatigue, atypical growth, and nystagmus. also difficulty with learning, sleep problems, and spasticity. So they were all the most common symptoms for both classic and conatal PMD. So after reporting the symptoms that individuals with PMD had experienced in the last 2 months, caregivers were asked to indicate, as I mentioned, on a scale of 1, which was least bothersome, to 10 being most bothersome, how bothersome the symptoms were for the individual with PMD. And so overall, difficulty with crawling, standing or walking was rated as the most bothersome symptom across the cohort, with an average of 7.9 out of 10. And although it was not as frequently reported as other symptoms, interestingly, constipation and sleep difficulties were considered as bothersome, as more bothersome than they were frequently occurring. Difficulty with manual dexterity, communicating, speaking, eating and or swallowing, holding up their head, and spasticity and mental health were all rated as very bothersome, with a rating of greater than 7 out of 10. And again, as you can see here, I included some anecdotes from some of the caregivers. And as you can see, constipation out of routine can be back right up. They're not good for eating, sleep being a real issue here, making the patient irritable, unable to interact with their surroundings, too tired to end up, being able to poo or pee, those being some of the real challenges here. And again, in their own words, caregivers highlighted communication, spasticity, mobility, as I mentioned already, constipation and mental health as the symptoms with the most impact on daily life. For example, spasticity, it affects aspects of his daily functioning. He can't go from A to B, but he wants to. Difficulty standing, walking and crawling for obvious reasons, but that makes him fully dependent 24/7. So over the last year, 61% of caregivers described their child's symptoms as being stable. 26% reported that their child's symptoms had deteriorated somewhat, and 8% described the condition as having worsened greatly, with only 5% having no response. But overall, people felt that PMD was being well managed and was relatively stable. Here, this slide just highlights activities of daily living that had a significant impact. And so just for reference, the darkest color pink were things that can't be done independently. The slightly lighter color pink are things that could be done with some assistance. Oranges can do without assistance, but with a little difficulty. And then the kind of greeny yellow color is being able to do things without any assistance at all and with no difficulty. And so I think one of the things that's highlighted here is that really the majority of PMD patients that were captured in this survey have a significant impairment in terms of independent living. So just looking at medication and treatment, the frequently used medications included vitamins and supplements, with about 60% of patients using that. Constipation medication was common, anti-spasticity medication, and also anti-epileptic medication was used. But there weren't really a lot of patients taking any medication to manage specific symptoms. Many participants used assistive devices, including a manual wheelchair, a walker, and also speech generating devices. And most participants were engaged in, or had previously engaged in at some point, additional therapy, with all patients having engaged in physical therapy at some point. 86% of participants having had speech therapy, occupational therapy was also common, and physical exercise too, and some patients were engaged in psychotherapy. So looking at future treatment of PMD, so this was the final section of the survey, and we asked caregivers to reflect upon treatment priorities and also future participation in any research studies and clinical trials. And so consistent with the symptoms that came up, treatment of mobility issues was the greatest priority for the caregivers, and they felt that that was also reflective of their children. Difficulty crawling, standing or walking, and also difficulty communicating were reported as being high priorities. Again, we asked caregivers to describe anecdotally the most significant unmet needs in managing PMD, the ability to communicate, stopping disease progression, long-term care, financial support as well were highlighted as the most significant unmet need in managing PMD. And they gave examples such as it would be helpful if those treatments are more supported by healthcare rather than just chemicals. Early speech and language support, communication is independence, or at least independence of mind. So trial participation, so most people were willing to participate in a clinical trial or a natural history study. So a natural history study is just an observational study. It doesn't include an intervention. The remaining participants weren't sure, with a small number feeling like they were unable or they wanted to participate in a clinical trial or a natural history study. So we asked the caregivers about the concerns relating to participating in a clinical trial or a natural history study, and they gave examples such as traveling to research facilities or centers being really the greatest concern, and that was also followed by the frequency of visits. The potential use of a placebo arm, so this is where a treatment would be administered, but it wouldn't have any therapy linked to it in a future trial. So that wouldn't prevent participation, which is encouraging, with most reporting that they would consider participating in a trial with a placebo arm, with about 79% of people saying that they would consider participating. Most participants reported that genetic testing, the use of lumbar punctures, so that's spinal taps where you collect spinal fluid, and MRI scans would not prevent them from participating in clinical trials. And even in the context of a natural history study, most participants were also willing to consider having an MRI scan and lumbar puncture procedures. And so this is highlighted here. You can see this is patients that would be, or caregivers that would be willing for their children to participate in natural history study, as I just mentioned. So just to conclude, so surveys such as this gather information about the disease really from the perspective of the people with the condition and their caregivers. The survey gathered data on when people are being diagnosed, and this allows us to inform strategies for reducing the time to diagnosis. The survey helps stakeholders better understand how the condition is currently being managed, and that allows us to inform the design of future clinical trials. It allowed us to identify the most bothersome symptoms, and we were able to develop a most bothersome symptom questionnaire that could be used in a clinical trial, and it can also inform other outcomes that might be useful. And then other really important outcome of this is it helped define what a meaningful treatment would do for people with PMD, but from the perspective of the individuals who are affected by the disease. And so we're hopeful that these insights can increase the chances of a success in a clinical trial, hopefully reduce the burden on clinical trial participants, and also help educate healthcare providers on PMD and improve the diagnosis and care. Does anyone have any questions? Yeah. can you speak to that, Nicole? So the question was how are the sleep problems and the genetics linked?
I'm afraid I don't have a good answer because the sleep problems are common in many patients with similar handicaps, independent of genetic diagnosis. So that's and we have I have patients with PMD who sleep like an angel every night. So I don't think it's specific to the genetic problem.
Any other questions? Yeah, any questions virtually or? We good? Yeah, so this data has been submitted to a journal, and so we're hoping that gets to the approval process. Journals always take some time to to review a publication, but this data will be published, and so it will be available because I think this is actually one of the largest studies of PMD, of caregivers, at least with 100 PMD participants. That represents quite a large number that are at least reporting on these symptoms. So we wanted to make sure this was published in the literature so that it can continue to inform multiple, academics and also anybody in industry as well. Yeah. So most of them, I can jump. Most of them were in the US. Let me find it. So this is it here. So most of them were in the US. Interestingly, there was quite a lot in Brazil. And then you can see we had a few patients represented in Europe, and then, we had the odd patient, one patient in quite a few countries. And I think this is just because the survey was pushed out through the PMD Foundation, so it was based on their outreach. I think the European Leukodystrophy Association also put this survey out, but it was purely dependent on the outreach. So obviously it doesn't represent all of the PMD patients, but I think it covers a good, at least gives perspectives from a number of different countries and different regions. Yeah. 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 Yeah, that was one of the other kind of limitations of this is we didn't translate the survey. If we had translated it, we may have had more caregivers participating. I think that's why we have kind of European bias and a US bias. There are patients in, for example, like there's a lot of patients in Japan and other countries as well, which aren't represented in this survey. Any other questions? No. Well, thank you so much.